Welcome to the Human Health Campus Paediatric Nuclear Medicine webinar series. This webinar is entitled Myocardial Perfusion Scintigraphy in Pediatric Cardiology and is presented by Pietro Zucchetta from Department of Nuclear Medicine at the University Hospital in Padova, Italy. I am pleased to present this seminar to you on behalf of the Nuclear Medicine and Diagnostic Imaging section of the International Atomic Energy Agency in collaboration with the European Association of Nuclear Medicine.
Nuclear medicine plays a well-defined critical role in adult cardiology because it represents a powerful diagnostic and prognostic tool in the management of ischemic heart disease. The spectrum of disease is completely different in pediatric cardiology, where atherosclerosis is absent and congenital heart disease malformations constitute the vast majority of the cases. Congenital heart defects occurring around 1% of live births and 30–40% of patients will need surgical correction. This is particularly true in 25% of patients affected by critical congenital heart defects. They will need early surgical treatment to prevent catastrophic consequences. Surgical treatment relies first and foremost on accurate morphological definition of the anatomical situation, and this is usually obtained by a combination of echocardiography, MRI, and angiography. The same holds true for the follow-up, which requires in many cases, even if not complex, lifelong monitoring, which is particularly significant considering the rising prevalence of congenital heart defects, as shown in this slide, and the increasing survival rate after treatment. Nuclear medicine plays a role when functional evaluation is required, for example, assessing pulmonary blood flow distribution or myocardial perfusion. Nuclear medicine techniques in pediatric cardiology share many general aspects with adult practice as radiopharmaceuticals, basic acquisition settings, and so on. But everything must be adapted to the single patient to obtain high-quality exams. It is worth to remember that the definition pediatric patient covers a dramatic evolution, from neonate to infant to preschool child up to adolescent. Therefore, modifications to the different steps of a diagnostic examination are specific of a particular age group and are tailored to the characteristics of the single patient. Modifications encompass the need to adequately inform and reassure child and parents, dose scaling, acquisition protocols adjustments to patient characteristics, and so on. We will review the main steps in setting up a myocardial perfusion scan for a pediatric patient. They can be summarized in 4 broad categories: patient preparation, stress test when required, crucial selection and administration, scanning. Patient preparation starts, as already observed, by detailed information of parents, accompanying persons, and of the child, when possible. The explanation to the child has to be adapted to the comprehension level, but it is essential to establish a direct relationship with the patient. The best way to obtain maximal cooperation from the child is to involve him in the setup of the exam and to inform and reassure the parents, who represents the emotional beacon for the child. Fasting is usually required, 3 hours in infants, 4–8 hours in older children, when a stress test is scheduled or when sedation is planned. In this case, details should be arranged with the anesthesiologist. Sedation is generally necessary up to 5–6 years of age, with some possible exceptions at both ends of the spectrum. It is possible to acquire good quality images without sedation in some neonates or infants, typically up to 6 months, taking advantage of the physiological post-feeding sleep in conjunction with some kind of gentle restraint, vacuum cushions, Velcro straps, etc. Stress testing requires the interruption of drugs interfering with heart rate, as beta blockers, whenever possible. Moreover, patients undergoing pharmacological stimulation with adenosine or dipyridamole should avoid xanthin-containing medications and beverages. Venous access must be established before starting the stress procedure and must be maintained up to the end to inject the radiotracer and for the possible administration of drugs antagonizing the side effects of the pharmacological stress. Stress tests can be performed using a physical stressor, treadmill or cycle ergometer, or pharmacological stimulation. Physical testing is more physiologic, but it is obviously impossible in younger children for the lack of suitable equipment and for the short attention span typical of this age group. Pharmacological stress is most often performed using drugs interfering with heart rate as beta blockers must be suspended before physical stress testing. Methylxanthines, particularly theophylline, aminophylline, and similar medications, are adenosine antagonists. They should be avoided, preferably for 24 hours before injection, and for the same reason, xanthin-containing beverages and foods, tea, coffee, chocolate, cola-based drinks, and some energetic drinks should be avoided for 12-48 hours before adenosine testing. The main contraindications are asthma, wheezing, atrioventricular block, and blood pressure disturbances, particularly hypotension. Even if side effects are usually mild and self-limiting, adenosine infusion must be performed in a hospital setting, with monitoring and cardiorespiratory resuscitation equipment available for immediate use if necessary. During the entire administration or physical stress, in the immediate period after it, continuous ECG monitoring is requested, in conjunction with blood pressure measurements. Adenosine is injected over 6 minutes at 0.14 mg kilo per minute. An infusion rate is better controlled by pump administration. The optimal setup would require a second venous access for the radiotracer injection, in order to keep a constant rate. This is obviously difficult to accomplish in younger patients, and most often a single access is the only possible solution. In this case, tracer injection must be performed as a quick bolus, because stopping adenosine infusion for more than a few seconds would reduce the pharmacological effect in the precise time point when maximal coronary artery dilatation is required. Besides, it is suggested to inject the tracer at the end of the infusion line to avoid an adenosine bolus when flushing the radiopharmaceutical. The recommended time point for tracer injection is 3 minutes after the start of adenosine infusion, leaving other 3 minutes of full pharmacological stimulation for the uptake of the tracer. If dipyridamole is used, the timing of tracer injection is delayed due to differences in pharmacokinetics of the vasodilator drug. The radiotracer is injected 2-3 minutes after the end of dipyridamole infusion, when the vasodilator effect is maximal. Theophylline can be injected, if necessary, only when tracer distribution is completed, more or less 2 minutes after tracer injection. 99-MTC-MIBI and 99-MTC-tetrophosmin are the preferred tracers for myocardial perfusion imaging in children. Both compounds have a fast blood clearance, and tissue uptake is proportional to myocardial blood flow, without significant redistribution, allowing image acquisition without relevant time constraints. Thallium is not recommended in children due to unfavorable dosimetry. The extracardiac distribution is slightly different when compared to adults, because children show higher hepatic retention, particularly in neonates and infants. Therefore, delayed imaging at 90 minutes after injection is recommended in these age groups to reduce interference with the inferior ventricular wall from liver tracer accumulation. Tracer dose reduction is usually performed by weight-based scaling of the standard adult dose, typically between 550 and 740 megabecquerels, using, for instance, the ESNM pediatric dose calculator. Dose calculation must be adapted to local regulations and available technology, balancing dose reduction and image quality. MIBI and tetrophosmin are usually well tolerated. The most frequent side effect is a transient metallic taste after injection, usually lasting 30-60 seconds. Images are required preferably with a dual-head camera in 90 degrees configuration, L configuration, positioning the patient on the standard table or in a dedicated cradle optimized for SPECT imaging. Sedation is usually required under 5-6 years of age, because SPECT imaging lasts 15-20 minutes and immobility is required for the full duration. Evaluation of myocardial perfusion in children needs high-quality images with the best spatial resolution, because children's heart is small and fast-beating. Therefore, high-resolution or ultra-high-resolution collimators must be used, selecting a tight orbit to minimize the distance between the chest wall and the detectors. It is also critical to select an adequate zoom-in factor, considering the size of the field of view and the size of the heart. It is possible to acquire gated studies, but it is advisable to use 10-12 gating intervals to keep an acceptable temporal resolution, even at the physiologic high cardiac rate often observed in children. Quantitative parameters derived from GSPECT acquisition must be carefully evaluated, because the commercially available computer packages may incur inaccuracies due to the small heart volume in smaller patients. Whenever possible, reconstruction should employ iterative algorithms and the so-called resolution recovery to improve resolution and image contrast. Image filtering must be adapted to the small size of the heart, avoiding overfiltering. The first case is a 9-year-old boy complaining of vague chest discomfort during exercise in the last 3 weeks. He had been operated during the first months of life for anomalous left coronary artery arising from the pulmonary artery, with successful correction. His development has been normal, with free physical activity. This is a schematic drawing representing the left coronary artery arising from the pulmonary trunk. Myocardial ischemia arises shortly after birth as a consequence of low-pressure perfusion with desaturated blood, when circulation shifts from parallel, as during fetal life, to the postnatal standard. Surgical correction requires transferring the origin of the anomalous coronary artery from the pulmonary trunk to the aorta, as shown in this drawing. Taking into account clinical history and symptoms, a stress-rest myocardial perfusion scintigraphy has been prescribed to confirm the presence of myocardial ischemia. The target frequency was reached during the test without clinical symptoms or ECG abnormalities. The dose of 99 mTC MIBI was scaled down using the ESNM dose calculator, and it was injected at the peak of the exercise, maintaining the maximal workload for 2 minutes. Images were acquired on a double-head large field of view gamma camera in 90 degrees configuration, using high-resolution parallel Holtz collimators and 128 by 128 pixel matrix. Acquisition zoom was set to 2.3, obtaining a significant magnification. Acquisition lasted for 25 minutes, and image reconstruction was performed by iterative reconstruction. The reconstructed images, reoriented in the 3 standard cardiac axes, show no evidence of hypoperfusion after injection during the stress test. Therefore, the rest study was omitted to avoid unnecessary radiation exposure. In the second case, a 10-year-old patient was referred to the Pediatric Cardiology department for occasional chest discomfort and palpitations, in some cases precipitated or exacerbated by physical exercise. The boy had been operated for dextrotransposition of the great arteries. DTGA is the most common cyanotic congenital heart lesion in neonates, and it is characterized by ventricular-arterial discordance. Aorta arises from the morphologic right ventricle, and the pulmonary artery arises from the morphologic left ventricle. Early surgical treatment is required in more than 90% of cases, with excellent survival. The most frequent treatment is the arterial switch, re-establishing the continuity between aorta and left ventricle and pulmonary artery and right ventricle. Coronary arteries are removed from their site and the pulmonary trunk and moved to the aorta. A stress echocardiography performed by the pediatric cardiologist showed a hypokinesia of the anterior wall of the left ventricle. Echographic findings and history, particularly surgical reconstruction of the left coronary artery due to its atresia at birth, were considered compatible with myocardial ischemia, and the stress-rest myocardial perfusion scintigraphy was requested. During the cyclohygrometer test, target frequency was reached without symptoms or ECG abnormalities. A weight-scaled dose of 99 mTc MIBI was injected during peak exercise, and images were acquired on a double-head gamma camera in 90 degrees configuration, using high-resolution parallel Hall collimators, 128 matrix, 2.5 acquisition zoom. Same dose and same parameters were used for the rest study 2 days later. In the upper row, we have stress short-axis images showing a prominent right ventricle which appears relatively hypoperfused when compared to the left ventricle. Images on the inferior row do not show changes in perfusion after injection at rest, excluding ischemia. The prominent right ventricle can be observed in some patients with congenital heart defects as a consequence of anomalous anatomy and/or function. Patient number 3 had a history similar to the previous one, in this case without known anomalies of the coronaries. The clinical suspicion depends on similar clinical and anamnestic elements. In this case, an adenosine test has been performed because the child was uncooperative during a prior exercise test. The pharmacological test was well tolerated, without significant side effects, and the target frequency was reached and maintained after 99 mTc MIBI injection. Images were acquired using the standard settings, which have been already described. Short-axis images obtained after adenosine show hypoperfusion of the anterolateral wall, which is normally perfused in the images acquired after rest injection, confirming the presence of reversible myocardial ischemia. The fourth patient is a 10-year-old girl complaining of chest pain at rest. She had no history of congenital or acquired heart disease, and her development and physical activity were normal. A deep Q wave was observed on wrist ECG, and echocardiography showed a small mitral cyst, which is a benign formation lined with endothelium, usually asymptomatic. Considering symptoms and ECG abnormalities, a stress-rest myocardial perfusion scintigraphy was prescribed. The cycloergometer test showed normal exercise capacity without symptoms or ECG abnormalities. Images were acquired with the usual protocol, which was used without modifications also for the acquisition after injection at rest. The vertical long-axis images show reversible ischemia of the anterior wall. A coronary compression secondary to a myocardial bridge was detected during further workup, confirming the innocence of the mitral cyst. Our last case is an 8-year-old boy complaining of episodic chest pain, not always related with exercise. He had been treated at 6 years of age for Kawasaki disease with coronaritis and giant aneurysms. Aneurysms did not resolve completely after treatment and remission, but were stable during the follow-up. Persisting coronary aneurysms are considered a risk factor for myocardial ischemia even years after Kawasaki disease. Therefore, a stress myocardial perfusion scintigraphy was performed. Exercise capacity and ECG were normal, and a weight-scaled dose of 99 mTc MIBI was injected at peak exercise. Acquisition followed the standard protocol. No perfusion disturbances were observed on the stress images. Consequently, the planned rest scintigraphy was cancelled, avoiding unnecessary radiation exposure. The symptoms disappeared without treatment and did not recur during the following 2 years. The slide gives an outline of the main technical points concerning myocardial perfusion scintigraphy in children. It must be stressed that thallium is not indicated as tracer in this age group because radiation exposure is high. Fast redistribution requires immediate acquisition after stress injection, which is difficult to accomplish in children, and image quality is low, particularly when SPECT images are required. The main indications for myocardial perfusion scintigraphy in children are outlined in this final slide.